Which of the following cellular processes is typical of the section of reversible injury noted in this patient? We have a 70-year-old woman with hypertension and hyperlipidemia who presents to the emergency with chief complaints of acute onset of impaired speech and comprehension and right-sided weakness for the last 1.5 hours. The patient is taking 2 antihypertensive medications and a statin, but she has not been receiving any antiplatelet drugs. Her BP is 136/94, heart rate is 84, respiratory rate is 50. Initial examination shows global aphasia, right homonymous hemianopia, and hemisensory loss. An acute ischemic stroke caused by distal left internal carotid artery occlusion with salvageable penumbral tissue is diagnosed based on a non-contrast CT, brain MRI, and catheter cerebral angiography. IV tissue plasminogen activator is given as a treatment with 3 hours of presentation. Which of the following processes is typical of this section of the okay, perfect, right? Reversible injury, we have decreased ATP ion imbalance due to your defect in Na plus K plus ATPase pump, cell swelling, nuclear chromatin swelling, and ribosomal detachment, and fatty chain. These are the different reversible injuries. Okay, what are the irreversible injury? Mitochondrial permeability, severe plasma membrane damage, calcium influx, caspase activation, lysosomal rupture, nuclear pycnosis, and karyorrhexis or karyolysis. That's the ultimate destruction from which you cannot revert back. Now, this patient is suffering from stroke, which is due to ischemia. They clearly mentioned that, correct? He has a focal deficit as well. Stroke is divided into, yeah, so basically, clinically, if I were to talk, stroke is divided into ischemic and hemorrhagic. Ischemic being the most common. Now, in that, we have embolic and thrombotic. And okay, lacunar strokes, those are other strokes. In embolic and thrombotic is the most common stroke. Now, I'm not sure how many of you are currently doing your clinical subjects. If you are, then you will definitely know how to differentiate between each of the stroke. I would have discussed it now, but it's not relevant to your syllabus, so I'll skip that. So just know this basic, okay? Like it's mentioned here too, that thrombotic stroke is the most common type, and it's because of the thrombus, and that happens because of your atherosclerosis plaque rupture. Emboli is coming from somewhere else. You know the definition, correct? And the hemorrhagic stroke most commonly is because of your hypertension, rupture of the aneurysms because of high BP. Okay, now, or even trauma. Now, this question is asking about the difference between reversible and irreversible cellular injury. The infarcted area represents your irreversible injury, and the penumbra represents your irreversible injury. I would suggest you guys to go back and read in one of your medicine books, if you can get it from your seniors, if you're junior, or if you're in first or second or third year. And I'm assuming the other final year med students have the book. Go back and just read this mechanism of stroke, right? What happens in your penumbra region, and when is it reversible or irreversible, and things like that. Okay, it's a very simple concept. It'll take just 2 minutes, right? On radiography, which we get CT scan done first to rule out whether it's ischemic or hemorrhagic. The ischemic penumbra is an area of ischemic tissue which appears at the outer rim of the infarct. So infarct will always appear as a hypodense lesion on your CT scans. But sometimes it so happens that within few hours you can never, even if there's an ischemia, it will not be shown on a CT. That is also there. It's possible. That's why we get another MRI done. Okay, now coming back to the question here. So outer rim of an infarct, you have that area of ischemic tissue called the penumbra. This is hazy in appearance. It's more closer to your blood supply as well. So the tissue is salvageable if revascularization is achieved. That is why we say stroke is a golden period, come fast, right? Now, the rationale of using this tissue plasminogen activator is your 1080 altiplase and stuff. That is to protect this penumbra zone. If we can salvage it, we'll salvage it. So we can avoid the FND, your focal neurological deficit, that is associated with that area of your infarct. I hope I'm clear, or it's not too much of clinical knowledge. I just hope so. You guys understood what I'm talking about. Okay. But as far as the takeaway from this question is your ATP. Other than that, I'm just giving you an extra information so that you guys have an extra edge when you're doing your questions.
Thanks for watching. Please give a thumbs up and subscribe for more.